Okay, thank you. So whenever we are studying about transplantation, please remember transplantation. First of all, we must have to learn about the definition for transplantation. So what is the definition for transplantation? See this slide, everyone. So the definition for transplantation. It is a graft or transplant, transfer of living cells and tissues and organs from one part of the body to another or from one individual to the another. So in simple words, what is transplantation? Transplantation is when you are transferring the living cells, tissues and organs from one part of the body to another part of the body, or from one individual you are transferring the organ or the tissues or cells to the other individual. It is known as transplantation. Okay, so this is your definition for transplantation, or you can write it as like this, that transplantation, for example, I have a patient who, this is the diagram of liver. Okay, this is the diagram for liver. So for example, patient is having liver cirrhosis. The patient is having what? Cirrhosis of the liver. If the patient is having cirrhosis of the liver, I cannot treat this patient. So what I am going to do in this patient, I must have to perform transplantation. Okay, because the liver is completely damaged. So when the liver is completely damaged, you cannot treat this patient by just giving medications or other things. You must have to transplant the patient, transplant the liver in this patient. So this is known as transplantation. For example, if anyone is going to ask you, what is the most common, you can say most common liver transplantation done in which patient? It is done in patients having hepatitis C. So if patient is having hepatitis C and due to that hepatitis C, the liver is damaged and it results in cirrhosis of the liver, it will cause, you must have to go for transplantation in this patient. Second most common cause for liver transplantation is your alcoholic liver disease. Okay. Second most common cause of liver transplantation in adults, it is your alcoholic liver disease. So two things you must have to remember at the moment right now. That liver transplantation, for example, I have a patient, and in this patient, what is happening that he develops hepatitis infection. And due to that hepatitis infection, especially hepatitis C virus infection, what happens? It damages the complete liver of the patient. When it damages the complete liver of the patient, what is going to happen? You cannot treat it. Now that it is converted into cirrhosis of the liver. So due to that cirrhosis of the liver, due to that hepatitis C viral infection, now you have to perform transplantation. So if anyone is going to ask you what is the most common, you can say liver transplantation done in which patient, your answer will be liver cirrhosis due to hepatitis C virus infection. Second most common cause of liver transplantation in adults, it is your alcoholic liver disease. So when the patient is having alcoholic liver disease, it will convert it into cirrhosis, and when it converted into cirrhosis, you will go for liver transplantation. Okay, but if anyone is going to ask from you that what is the most common liver transplantation done in children, so when you are going to ask that liver transplantation in children, then your answer will be biliary atresia. Okay, it will be biliary atresia. So these are the important points which you must have to remember. Okay, biliary atresia, it is the most common cause. If children is having biliary atresia, you will go for liver transplantation. Okay, so see here, very simple. You are transplanting liver from one person to another person. So this is the definition for transplantation. Now coming into the second slide. Can you see the second slide? Okay, now see here, everyone. So what can be the other definition for transplantation? Surgical operation in which failure or damaged organ, see here the words, the damaged organ in the human body is removed and now it is replaced with a functioning organ is known as transplantation. Okay, so I just give you an example of what? I give you an example of cirrhosis. So patient is having cirrhosis. When patient is having cirrhosis, the liver is not performing its function. So when the liver is not performing its function, what you are going to do? Now the liver is completely damaged. Liver cannot perform its function. So when the liver cannot perform its function, you will go for what? You will go for liver transplantation. Liver transplantation. Okay. So see here, second definition for for transplantation itself is what? When any part or organ or tissues or cells are damaged in the human body, you will just remove that damaged organ, cells, or tissue, and now you replace it with the functioning organ, cells, or tissue. It is known as what? It is known as transplantation. Okay. So you understand the definition for transplantation. Okay. Now coming into the second thing. See here. The donated organ may be from deceased donor, a living donor, or it can be from any animal also. So now you have to take organs because I have patient with liver cirrhosis. So if I have patient with liver cirrhosis, I must have to transplant the liver. So what I am going to do? I must have to take the liver from a recipient, from a donor, not recipient, from a donor. So from where I can get the donor? See, I will get the donor from the deceased donor. I can use the living donors also. Even I can take the organs from some animals also. Okay. So you can take the donated organs from a deceased donor, a living donor, or an animals also. Organs that can be transplanted are heart, kidneys, livers, lungs, pancreas, intestine, and thymus gland, etc., etc. Okay. So these are the organs which you can be transplanted. Okay. Now coming into the history of the transplantation. So what is the history of transplantation? See here, everyone. The modern era of transplantation begins in the 1950s. This history is very, very important because many questions are asking from only the history also. Okay. But please remember the very important thing which all of you must have to remember is this one. The first successful kidney transplant was a living donor transplant performed between identical twins in 1954. And these identical twins are which one? They are monozygotic identical twins. Monozygotic identical twins. Monozygotic. Okay. And it was done by Dr. Joseph Murray and its colleagues in 1954. So see here, very simple thing. I just explained to you what? The transplantation, whenever you are studying, you must have to know the immunological response of the patient, immunological system of the patient, right? So see here, whenever the first transplantation was done by Dr. Joseph Murray in 1954. But when he performed, why that transplantation was successful? Because the transplantation was done between two identical twins. Okay? It was done between two identical twins. So when it's done between two identical twins, there is no immunological response. Okay? There is no immunological response. So when there is no immunological response, that transplantation becomes successful. So if anyone is going to ask you, what is the first successful transplantation? Your answer will be very simple, sir. The first successful transplantation was done by Dr. Joseph Murray in 1954. And why it was successful? Because it was occurred between the two identical twins. So when it occurs between the two identical twins, there is no immunological response. Okay, so that was your first successful transplantation. Okay, now see here next thing. This is our Dr. Joseph Murray. Okay, So see here that Dr. Joseph Murray in 1954 performed the first successful transplantation between the identical twins Ronald and Richard. Okay, and it reduced the problems of an immune reaction. And for this later, Dr. Murray received the Nobel Prize for Medicine in 1990 also. Okay, the recipient, Richard Hendrick, died 8 years after transplantation. So see here, the first successful transplantation was done in 1954. And it was successful because the patient lives after transplantation for next 8 years. So see, this is how you are going to help the patient, prolong the lifespan of the patient. So it increases the lifespan of Richard Hendrick by 8 years. And for that thing, Dr. J. Murray get what? Nobel Prize in 1990. Okay, so this was a successful, you can say, transplantation. Successful transplantation. But now I have one very simple question from all of you. Now, Dr. J. Murray in 1954 performed between two identical twins. So when he performed between two identical twins, there is no immunological reaction. So they said that, okay, transplantation is very successful. Now we can perform it in all the patients. So what is going to happen now? Now he tried to do transplantation between two different individuals. It will be successful or it will not be successful? No. Very good. Why it is not successful? Because of immunological reaction. Okay, because of what? Immunological reaction. Because when you are going to transplant in two different persons, the immune system of the recipient, it is going to give reaction to that donor graft. It can be kidney, it can be liver, any organ which is going to be transplantation in the patient. So there will be immunological reaction. That's why the transplantation was not successful. So I have now one very simple question from all of you. If it was not successful, then how we can make it successful? Very simple answer. We can make it successful by using some drugs to suppress the immune system of the patient. Okay, so that the recipient patient is not going to give any immune response to that donor graft or tissue. Clear to everyone? So for that purpose, now the doctors started what? Now see the next slide, everyone. See here. Now they start developing what? Immunosuppressive therapy. Because at that time, there was no effective immunosuppressive therapy was available. Okay. So that's why now they started to develop immunosuppressive agents. Like in 1959, Schwartz and Demschek discovered six mercaptopurine that have immunosuppressive properties. Kalnick showed that azathioprine can prevent ejection of canine kidney transplants also in the patient. Okay, so now doctors started what? They start developing what? They start developing immunosuppressive therapies. So when they start developing immunosuppressive therapies, what they are trying to do? They are trying to suppress the immune response of the patient. They're trying to suppress what? The immune response of the patient. Okay, now see here. So in 1960s, in the early 1960s, a combination of azathioprine and corticosteroids was used with moderate success to prevent graft rejection after kidney transplantation. Okay, so now after the development of immunosuppressive agents, they start performing kidney transplantations in different persons. But see here, still they have very problems. To overcome that problem, see here, there is a development of cyclosporine. And after the development of cyclosporine, please remember this cyclosporine, it will block interleukin 2 in the patient. Okay, it will block interleukin 2 in the patient and it will not allow the lymphocytes to proliferate. So when it will not allow the lymphocytes to proliferate, now you can see that it will improve the results of renal transplantation, but it also allowed transplantation of heart and liver also to be undertaken. Okay. So now what you must have to remember that after Joseph Murray, now listen once again, Joseph Murray do in identical twins that was successful. After then, he tried to perform, or doctors tried to perform transplantation in different individuals. But when they try to perform transplantation in different individuals, what happened? That there is an immune reaction and that results in graft rejection, right? So to prevent that graft rejection, now the doctor starts developing what? Immunosuppressive agents. So when they start developing immunosuppressive agents, what is going to do? It will suppress the immune system. It will prevent the graft rejection in the patient. And after the development of cyclosporine, especially, okay, we can use cyclosporine, tacrolimus, we have corticosteroid, we have various number of agents to perform immunosuppressive therapy in the patient. And when we started that immunosuppressive therapy in the patient who received the graft, what happened now? The patient's immune system is not going to give immune response to that graft or that organ. Okay, it's clear to everyone. Okay, so this is how they start working use of immunosuppressive agents. Okay, so now coming into the types of graft, very important, and I want all of you to be very clear in this slide. And many MCQs are making only from this slide. Okay, so there are 4 types of graft which you must have to remember. Number 1, autograft. Number 2, isograft. Number 3, allograft. And number 4 is xenograft. So first of all, you must have to understand what is autograft. See here, everyone. Just see the slide and I will explain to you. Autograft is the graft in the same person from one part of the body to the other part. For example, skin grafting, hair transplantations, bone transplantation. Now I have one patient with burn injury. See here, everyone. For example, patient is having burn injury to this exposed area, which I am highlighting in green color. So patient is having burn injury. B-U-R-N, burn injury. So what I will do now, I will take a graft from here, from non-exposed area. And now I will take this graft from the same person, not from other person. I will take the graft from this same individual, from his thigh region, and now I will transplant it here. Okay, so this is known as autograft. This is known as what? Autograft. Clear? It is clear to everyone. Okay, now I have one question from all of you. In autograft, there will be any immune response to the patient? No. Very good. So please remember, there will be no immunological response in the patient. So I have one more question. In this patient, you required immunosuppressive therapy. Very good. So in this patient, if you are using autograft, there is no need for immunosuppressive therapy. Okay. For example, hair transplantation. No, I have lot of hair, so I don't need hair transplantation. Okay. So hair transplantation, for example, skin graft, you can take it. For example, patient is having a burn injury on the face. So this is the exposed area. So what I will do, I will take graft from my thigh region and I will place it here. So if the graft is taken in a same person, but from one area to the another area, this is known as what? Autograft. This is known as what? Autograft. So second is your what? Second is your isograft. So what is isograft? Between the identical twins. But which identical twins? Monozygotic identical twins. Which twins? monozygotic identical twins. So in identical twins, which was performed by J. Murray in 1954. J. Murray in 1954. He performed it in 1954. So in identical twins, will there be any immunological response? No immunological response. Very good. So there is no immunological response. Do you need any immunosuppressive therapy in this patient? No. You don't need any immunosuppressive therapy in this patient. Okay? But it is very difficult to find two identical twins. Dr. Ali is only one Dr. Ali. There is not second Dr. Ali. Okay? So it's very difficult. So third one is your what? This is your allograft. So what is allograft? This is between different members of the same species. Okay. So if I take graft, for example, I take graft from me and transplant it into my student. This is known as what? Allograft. So from one different members of the same species is known as allograft. For example, kidney transplantation, heart, lungs, and liver transplantation, etc. etc. So please tell me in allograft, where there will be any immunological reaction? Yes, very good. So there will be immunological reaction. So that's why whenever I am using allograft, I must have to give what? Immunosuppressive therapy in the patient. I must have to give what? Immunosuppressive therapy or immunosuppressive agents to the patient to prevent graft rejection in the patient. It is clear to everyone? Clear? Okay. Fourth one is xenograft. Now, what is xenograft? You can see in the picture which I place it here. It is between two different species, like monkey to man. But xenograft, we are mainly using which one? See here, we are mainly using pork, especially in cardiac surgeries. Okay. In fourth year, maybe you are going to study valvular heart diseases, and in valvular heart diseases, you are going to replace, you can say, the walls of the heart, mitral valve, tricuspid valve. So when you are performing valvular heart surgeries in patients with valvular heart diseases, you can use the walls of the pork because pork is identical. You can say it's more similar to the, you can say, human beings. So we can use it in cardiac surgery. But whenever you are using pork walls in the surgeries, it is known as xenograft. So in xenograft, you require immunosuppressive therapy. Yes, you require immunosuppressive therapy. You require, there will be immunoresponse. Yes, there will be immune response in the patient. So very, very simple. See here once again, four types of graft which you must have to remember. Number one is autograft. I take from my skin, from here and transplant it here. It is known as what? Autograft. Clear? Second is your what? Isograph between two identical twins. Ali sir, transplantation is done. It is your what? It is your isograph. Allograph. If I donate my kidney and transplant it to my student who is sitting there, then it will be your which graft? It will be allograft. But if I have, for example, if any person develop valvular heart disease and due to that valvular heart disease, you must have to change the walls of the heart of the patient. Then you are using pork walls, which are under the category of biological walls. Now this is known as xenograft. So what is xenograft? Between two different species, from pork to human beings, from monkey to human beings. So this is xenograft. So xenograft and allograft are the two grafts in which there will be immunological response from the patient, and there will be what? In these two grafts, you must have to use what? You must have to use immunosuppressive agents in both of these grafts. Clear to everyone? Okay. Now coming into the next slide now. So if this slide is clear, okay. Now see this slide now. So what are the allografts which you must have to remember? See, allografts provoke a powerful immune response that results in rapid graft rejection unless immunosuppressive therapy is given, which I already explained to all of you. But what you must have to remember that allograft rejection is due to an immune response. It is not an inflammatory response. And that immune response is mainly given to you by your T lymphocytes. Okay, so T lymphocytes plays an essential role in mediating rejection in the patient. Okay, T lymphocytes plays an important role in mediating rejection of the patient. So if anyone is going to ask you why the patient is developing graft rejection, so you can simply answer them that graft rejection, it is an immune response, and that immune response is due to the T lymphocytes. Mainly, your T lymphocytes play an essential role in graft rejection. So this is your MCQ which you must have to remember that T lymphocytes will mainly play a role in your graft rejection. Okay, it will mainly play a role in your what? Graft rejection. Okay, it's not an inflammatory response. Please remember it forever. Transplantation, when you are doing, and if there's any graft rejection occurring in the patient, it is not an inflammatory response. It is a immunological response to that graft. Okay, and which cells are mainly responsible? Your T lymphocytes are mainly responsible. Okay. Now coming into the next slide. Now see this slide, everyone. All the students who are hearing or listening to me, please see this slide very carefully. So now I tell you four types of graft before this slide. Autograft, isograft, allograft, and which one? Xenograft. Okay. Now there are two other types of graft. Number one is orthotopic graft. Number two is heterotopic graft. So what is orthotopic graft? If you place a graft in its normal anatomical site, it is known as orthotopic graft. Okay. For example, patient is having liver cirrhosis. And in liver cirrhosis, I remove the liver and place the liver in its normal anatomical site. It is known as orthotopic graft. It is known as what? Orthotopic graft. But if I place a graft different from its anatomical site is known as heterotopic graft. It is known as which graft? Heterotopic graft. See the diagram, all students. Now in this diagram, I am showing to you renal transplantation. So what important points for renal transplantation you must have to remember? Number one thing, what you must have to remember, we always prefer left kidney of the patient. Why we prefer left kidney of the patient? This is the reason which I am highlighting in green color. This is your what? This is your inferior vena cava. And inferior vena cava is slightly on the right side of your body. So that's why you are preferring, not you have to prefer left kidney in the patient. Left kidney in the patient. Why? Because the left renal vein is longer. Left renal vein is longer. That's why we always prefer left kidney of the patient. Yes, you have to check all the functions. If the kidney of the donor is working properly, for example, a donor comes to me and says to me, I want to donate my kidney, I must have to perform various investigations. I must have to check that both the kidneys of the patient is working properly. And after that, if I want to take his kidney, I will prefer the left kidney or left kidney. Why? Because the left renal vein is longer as compared to your right renal vein. See here, I am now highlighting in red color the right renal vein. The right renal vein is shorter. See the diagram also, students. See, it is shorter. But if I highlight the left renal vein, the left renal vein is longer. That's why I will prefer left kidney for donation in the patient. Number 1 point, what you must have to remember. Second point, after taking the kidney, I transplant the kidney in the iliac fossa. Which fossa? This is your iliac fossa. And this is the most common site where you are going to transplant the kidney. Most common site is your iliac fossa. Why we are using the iliac fossa? When you are placing the kidney in the iliac fossa, it is not now in your renal fossa. So now the anatomical position of the kidney is changed. And when it is changed, now I will call it as heterotopic graft. I will call it as which graft? Heterotopic graft. And see here, when I place it here, I have to perform here 3 anastomosis in the patient. 3 anastomosis in the patient. See here, everyone. I will make it in dark color. See, first anastomosis, renal vein with the external iliac vein. Second anastomosis, which I am highlighting in blue color, this one, renal artery with the external iliac artery. And third anastomosis, which I am performing, is this one, which I am highlighting in black color. Ureter with the urinary bladder of the patient. So I am performing 3 anastomosis. 3 anastomosis. Okay. Renal vein with external iliac vein. This will be, you can see, renal vein with external iliac vein, renal artery with external iliac artery, ureter with the urinary bladder. For these 2 anastomosis of arteries and vein, I will use proline suture. Okay, which suture? Proline suture. The best suture for vascular anastomosis is proline suture. Please remember it forever. The best suture for vascular anastomosis is proline suture. Okay, which suture? Proline suture. Now, for suturing the ureter with the bladder, for suturing the ureter with the bladder, I will use vicryl suture. Okay. Vicryl is violet in color. Most commonly used suture in the surgeons or in the surgical department. It is your vicryl. Okay. In GIT surgeries, urinary bladder, gallbladder surgeries, ureter, we mainly use vicryl suture. Vicryl is violet in color. That's why I highlighted on my slide violet in color. Proline is the best suture for vascular anastomosis. Vascular anastomosis. It is the best suture for vascular anastomosis. So see here. So it is easy for me to transplant the kidney here to make these anastomosis as compared to here. So most commonly heterotopic kidney transplantation or renal transplantation, I will perform where? In the iliac fossa. In which fossa? Iliac fossa. But you must have to remember 2 things. See here, orthotopic and heterotopic, right? Heterotopic, I just explained to you that when I want to perform kidney transplantation, I will place it where? Not in the renal fossa. I will place it in the iliac fossa. Because from iliac fossa, it will be easy for me to perform 3 anastomosis. Number one is renal artery with external iliac artery. Number two is renal vein with external iliac vein. Number three is ureter with the urinary bladder. Okay, so I will make these three anastomosis and I will place the kidney in the iliac fossa in retroperitoneal space. Which space? Retroperitoneal space. Okay, and please remember one more point which all of you must have to remember, that most commonly renal transplantation in adults is due to the chronic kidney disease secondary to the diabetic nephropathy. Okay, so patient is having diabetic nephropathy, and due to that diabetic nephropathy, patient develops chronic renal failure or chronic kidney disease, and due to that disease, kidney is now not performing its proper function. What is the function of kidney? To form urine, to control the glomerular filtration rate of the patient. Okay, so if it is not working properly, you will go for what? Renal transplantation. There are also many other reasons for renal transplant. It can be polycystic disease, it can be any other disease, but most commonly in adults, chronic kidney failure secondary due to diabetic nephropathy. Secondary due to what? Diabetic nephropathy. In children, I will write C only. Okay. In children, it is due to the glomerulonephritis. It is due to the glomerulonephritis. So these two are the also important point which you must have to remember. But please remember, whenever you are going for renal transplantation and anyone of you wants to donate the kidney, and if both the kidneys are working properly, I will prefer which kidney? I will prefer left kidney of the patient. Why? Because left renal vein is longer as compared to your right renal vein, which I am highlighting in green color. Okay, it is clear to all of you. It's clear? Sure? Okay. So this is your orthotopic graft and heterotopic graft. Okay. Now coming into the some important definitions relating to the graft. So see here, allograft is what? Organ tissue transplanted from one individual to another. Xenograft, graft performed between two different species, from pork to man. It is two different species. Orthotopic graft placed in its normal anatomical position. It is orthotopic graft. Heterotopic graft, when you place it in not its normal anatomical site, like in kidneys, we are placing in it where? In iliac fossa. Okay. Most commonly, we will place it where? In iliac fossa. Alloantigens are the transplant antigen. We will discuss it later. And then we have alloantibodies, that the transplant antibodies. And last one is our HLA antigen. Very, very important. Please remember it forever. HLA is the main trigger of graft rejection. Human leukocyte antigens are the most common cause of graft rejection. This is your MCQ which you must have to remember forever. So if anyone is going to ask you, what is the most common cause of graft rejection? Your answer will be HLA antigen. Your answer will be what? HLE antigen, human leukocyte antigen. This is your MCQ which you must have to remember. Okay. Now see here, how this graft rejection occurs in the patient. I will explain the process in later slide, but at the moment, just I will tell you that graft rejection in the patient is due to, there are two main causes. Number one is ABO antigens, and number two is your HLA antigens. Okay, which antigens? HLA antigen. Graft rejection response is due to allelic differences at polymorphic genes. that give rise to histocompatibility antigens or transplant antigens, which can be ABO group antigens and it can be HLA antigens. But if I give you which is the most common one, your answer will be HLA. So if I make an MCQ here right now in front of all of you, which is the most common cause of graft rejection? Most common cause of graft rejection. And I give you options A antigen, B antigen, HLA antigen. Your answer will be what? Your answer will be HLA antigen. Your answer will be what? HLA antigen. So please remember it forever. I just make MCQ in front of you. Very simple. Most common cause of graft rejection. Option number one, A antigen. Option number two, B antigen. Option number three, AB antigen. Option number four, HLA antigen. Your answer will be what? HLA antigen. Clear to everyone? Okay. HLA antigen. So first of all, we must have to know ABO antigen. So ABO antigens, I think you already studied about that. If on the blood, you can say if antigen A is present in your body, your blood group will be A blood group. If antigen B is present on your body, your blood group will be B. If antigen AB is present on your RBCs, it will be AB antigen. So what you are going to do, see here, to ensure that the recipients do not unintentionally receive a graft that is ABO blood group incompatible. So if ABO blood groups are incompatible, it can also cause graft rejection in the patient. Okay. Permissible transplants are from group O donor to group O, AB and AB recipient, group A donor to group A or AB recipient, group B donor to group B or AB recipient, or group AB donor only to group AB recipients. So I will just, and please, I will just show you another slide here. 1 second. See this one. So just remember this slide. If patient blood group is A, it means in his RBCs, A antigen must be present. If blood group is B, in his RBCs, B antigen is present. If blood group is AB, AB antigen must be present in. In blood group O, there is no antigen is present. But please remember one important MCQ which you must have to remember, that in all these blood groups, H antigen is present. H antigen is present here. H antigen is present here. H antigen is present here. H present antigen is also present in blood group A also. So if ever you are writing blood group O, you cannot write there is no antigen present. There is presence of which antigen? H antigen is present. From H antigen, further there is formation of A antigen, B antigen, and AB antigens. Clear? So H antigen will be present in blood group O also. Okay. So if any one of you is having blood group O, yes, it means there is no A antigen, no B antigen, but there is presence of which antigen? H antigen is present. Which antigen? H antigen is present. Okay. So ABO, you must have to perform cross matching in the patient. ABO compatibility is important before graft rejection. It is very, very important. Okay. After ABO, what you must have to remember is your HLE antigen. So see here the first slide which I highlight here in the first line. Most common cause of graft rejection is your HLA antigen. This is your MCQ which you must have to remember. MCQ. And this HLA antigens is divided into two classes. Class 1 and class 2. This is class 2. Class 2. Class 1 and class 2 HLA antigen. These HLA antigens are highly polymorphic. Whenever you are using the terminology polymorphic, it means it is highly different in all the patients, in all the persons. It's highly differential in all the persons. Okay. It's highly polymorphic. It is different in me. It is different in you. It is highly polymorphic. And it is the most important in organ transplantation. So in organ transplantation, the most important is your HLA antigen. And this HLA antigens, they are encoded by a gene. That gene is your MHC gene, major histocompatibility complex, which is present on the short arm of chromosome number 6. Okay, which is present on the short arm of chromosome number 6. Okay, so this is your HLA antigen. Now, first of all, you must have to remember where these HLA antigens are present. So, class 1, see here, it is class 1, so it means it will have only one letter. So you can write it HLA antigens as A, B, and C. That's it. Just remember these three. HLA1, so there will be only one letter. A, B, and C, HLA1 antigen. Class 2 antigens. 2. So it means it is having two words present in it. Okay. DP, DQ, and DR. That's it. Class 1 antigens are present in all your nucleated cells. Class 2 antigens are your antigen presenting cells. So they are your what? They are your antigen presenting cells. So when they are your antigen presenting cells, they are present on the dendritic cells, macrophages, and B lymphocytes. Okay. So now you must have to do what? You must have to match all these antigens in the patient. Okay. In the donor and recipient, you have to match what? HLA class 1 and class 2 antigens. Okay. So HLA class 1 are your which one? A, B, and C are your HLA class 1 antigens. HLA class 2 are your which antigens? DP, DQ, and DER. Okay. So now, see here, see this table now. So class 1, A, B, and C, class 2, DR, DP, and DQ. So when these antigens are present, you have to match it. If you are not going to match it between the donor and the recipient, there will be what? There will be graft rejection. There will be what? Graft rejection. So how you are going? So HLA, A, B, and C, and DR, DP, and DQ must be matched completely to have low risk of graft rejection. So if you want to prevent graft rejection in a patient, you must have to do what? You must have to match it between the donor and the recipient. Donor and recipient, both these two. But if anyone is going to ask me, sir, for transplantation, which are the most important ones which must be matched, your answer will be HLA antigen, B antigen, and DR antigen. And DR must be 100% matched. This is the most important one. The most important one, which must be matched. If it is not matched, there will be graft rejection, especially in renal transplantation. Especially in renal transplantation. So if I want to perform renal, so if all transplantation HLA matching is must, but please remember in transplantation, these must be matched. Okay. A, B and DR. And if you are going to ask me, sir, which one is the most important one? Your answer will be DR. Your answer will be what? DR. Okay. Till now everything is clear? Okay. So see here. First thing what I explained to you, what HLE antigens are the most common cause of your graft rejection, right? This is the most common cause of graft rejection, that is your HLA antigen. So what you are going to do, you have to perform HLA matching between the donor and recipient so that there will be no graft rejection. Okay. And now you have two classes of HLA. HLA class 1, HLA class 2. Class 1 is having 1. So it will be having one letter A, B, C. That's it. Class 2, I am saying 2. So it presents with two letters DP, DQ, DR. So all these must be matched before performing transplantation. But see here, very simple. If you ask me, sir, which are the most important ones which must be matched before transplantation, then I will say to you, you must have to match HLA-A antigen, HLA-B, and DR. And out of these three, which is the most important one? Your answer will be what? DR antigen. DR antigen. Clear? Okay. Now coming to the next point. So whenever, now I will explain you how the graft rejection occurs in the patient. Listen it very carefully. Graft rejection, first of all, I will explain you class 1. To remember class 1 and class 2, you must have to know the rule of 8. Rule of 8. So what is rule of 8? Okay. Rule of 8 is what? Because they are going to act on T lymphocytes. In the starting of my lecture, I explained to you that the graft rejection is mainly responsible for your T lymphocytes. So now you have various types of T lymphocytes. For example, you have CD4 T cells. You have CD8 T cells. So I will follow the rule of 8. 8 multiplied by HLA class 1. So it will be how much? It will be 8. CD4 multiplied by HLA class 2. So it will be 8. So please remember HLA class 1 will act on CD8 cells, CD8 T lymphocytes. Class 2, 2 multiplied by 4, then it will becomes 8. It will act by CD4 T cells. Clear to everyone? This is the rule of 8. So how now it is going to happen? Now listen very carefully. HLA, this HLA, it will be expressed by the graft. And when it is going to be expressed by the graft, see here, when it is going to express by the graft, it will activate T cells. And when it will activate the T cells, it will stimulate the T cells in response to interleukin 2, in response to interleukin 2 and other T cell growth factors. Okay. And when it stimulates, now what is going to happen? Now see here, this is the important point which you must have to remember. CD8 T cells, it will recognize HLA1 or HLA2. It will recognize HLA1. So CD8 T cells will recognize HLA1 antigens which are expressed on the graft cells, and now it is going to form what? It is going to release some molecules like perforins and granzymes. And now it will destroy the graft. Okay? Clear to everyone? Now listen once again. I think you don't clear it. Once again, listen. I will try to explain it in simple words. You have to perform HLA matching. Number one thing. You have to perform what? HLA matching. You have HLA class 1, you have HLA class 2. These will be expressed by the graft. It will be expressed by the graft. So when you place the graft in the patient, for example, my hand, this is the graft. You place it in the patient, it will be expressed on the surface of the graft. HLA antigens. Now the T lymphocytes which is present in the blood of the recipient. These T lymphocytes will come here and it will recognize this graft as a foreign body. And when it will recognize it as a foreign body, it will try to damage this foreign body, kill this foreign body. So what it will do? T cells have now two categories, CD4 and CD8 cells. CD8 will act by HLA class 1 only. CD4 will act by HLA class 2 only. So what happened? CD4, CD8 T cells will recognize HLA1 antigens. And when they recognize HLA1 antigen, they are going to release these chemical mediators like perforin and granzymes, and now it is going to damage the graft. Clear? Clear? Okay. Now second is your class 2 now. So class 2 is your which one? CD4 cells. CD4 T lymphocytes or CD4 cells. Right? So CD4 T cells, see here now. Now it will recognize HLA class 2 antigens which are present on the graft. Okay, it will recognize donor, you can say class 2 antigens. And when it will recognize donor class 2 antigens, now it will release interferon gamma. Interferon gamma. And this interferon gamma will ask macrophages to come and destroy this foreign body. See, it is not destroying itself. Here in class 1, what is happening? Class 1 is by CD8 cells. And CD8 cells are doing what? They are releasing lytic molecules like perforins and granzymes to directly damage the graft. Right? It is acting directly. But class 2 is not acting directly. Class 2 is doing what? Class 2 is releasing some pro-inflammatory cytokines like interferon gamma. This interferon gamma will ask the macrophages, there is some foreign body present, go there and kill that foreign body. In our case, it is the graft. So clear? Clear to everyone? So this is by macrophages. Or your CD4 cell will do what? It is going to act on your B lymphocytes. And when it is going to act on the B lymphocytes, it will make the B lymphocytes plasma cells. And these plasma cells will form what? Allo antibodies. Allo antibodies, and these antibodies are going to cause target cell injury to the patient. Okay, so very simple. Once again, see here how graft rejection is occurring. To prevent graft rejection, what you have to do? You have to perform HLA matching. Now you have two HLA, HLA class 1, HLA class 2. Class 1, I am going to follow the rule of 8. Class 1, so it cannot be CD4, it will be CD8. That's it. Okay. Class 2, 2 multiplied by 4 is equal to 8. Okay. It means it is HLA class 2. So class 1 is our which T lymphocyte? CD8 lymphocytes, T lymphocytes. Now the CD8 lymphocyte will do what? It will make inflammatory cytokines, and now it will damage directly the target cells by forming what? Perforins and granzymes. And it will cause graft rejection in the patient. Second is your what? CD4 cells. CD4 cells say, no, I am not going directly kill the damage the graft. I am not going directly. What I will do? I will release some mediators like interferon gammas, and these interferon gammas will give signal to the macrophages, and now these macrophages will come and it will now damage the graft in the patient. Okay. Or CD4 will do what? Okay, T cells are working. Now I will ask B lymphocytes also to work. So it will stimulate the B lymphocytes. B lymphocytes will be differentiated into plasma cells. And from these plasma cells, there is formation of what? Allo antibodies. Because you are performing what? Allograft. Right? So there will be formation of what? Antibodies against that graft organ, and it will damage now. Okay, so this is your graft rejection. So just it is by CD4 and CD8 T lymphocyte. It is clear to everyone. Clear? So just remember the rule of 8. If you remember the rule of 8, you will never make a mistake here. Clear? Okay. Now next point. Now see here, types of allograft rejection. So there are 3 types of allograft rejection. Number 1 is hyperacute rejection. Number 2 is acute rejection. Number 3 is chronic rejection. So here your another MCQ is coming. See here. Which is the most common cause of graft failure? Your answer will be what? Your answer will be chronic rejection. Okay. If I ask you, what is the most common cause of graft rejection, then your answer will be what? HLA antigens. This is the most common cause of graft rejection, but graft failure. Okay, but if I ask you what is the most common cause of graft rejection, graft failure, then your answer will be chronic rejection. Then your answer will be what? Chronic rejection. So 3 rejections you must have to remember. Number 1, hyperacute. Number 2 is acute. Number 3 is chronic. Which is the most common cause of graft failure? Your answer will be chronic rejection. It's not hyperacute. It's not acute. It is chronic rejection. Okay. So first of all, we must have to know what is hyperacute rejection. One second. What is hyperacute rejection? See here, everyone. Hyperacute rejection means what? It means that you are performing, for example, you are performing renal transplantation. You take a kidney from the patient and now you transplant it into the patient. And as you transplant it into the patient, it immediately rejects that kidney. How you are going to know? The kidney will change its color. It will become dusky color, dusky in color, dusky color. And there will be no urine formation, no urine formation, no urine formation. So if you, for example, you are surgeon, you are performing transplantation and you are performing renal transplantation, for example, and you place the kidney, and after placing the kidney changes its color and there is no urine formation after transplantation, It is your hyperacute rejection. It is your which rejection? Hyperacute rejection. And this rejection occurs within minutes and hours. Within minutes to hours. So this is the first point which you must have to remember. It occurs within minutes to hours. And what is the cause? The cause of hyperacute rejection is preformed antibodies against your HLA antigens, or it can be your ABO antigens also. Okay. So antibodies are already preformed. Okay. Very simple example. For example, you didn't perform proper HLA matching. You didn't perform proper, you can say, cross matching in ABO antigens. So what can happen? It will immediately give you reaction. There are already preformed antibodies present, and now it will cause what? It will cause hyperacute rejection. Okay, it will cause what? Hyperacute rejection. It can also occur if an ABO blood group incompatible organ graft is performed. Okay. So if there is ABO incompatibility, immediately the kidney will give you the reaction. And this is known as what? Hyperacute rejection. And please remember, hyperacute rejection, it is your type 2 hypersensitivity reaction. It is your type 2 hypersensitivity reaction. Please remember it forever. Type 2 hypersensitivity reaction. Hyperacute rejection. It is your type 2 hypersensitivity rejection. And very important point which you all must have to remember, that kidney transplants are vulnerable to hyperacute graft, whereas, now see here, whereas heart and liver transplants are relatively resistant. It is not clear why the liver is resistant to hyperacute rejection. So what you must have to remember in hyperacute rejection, listen once again. Hyperacute rejection occurs within minutes to hours. Immediately when you perform transplantation, their organ and the body gives reaction, it means it is hyperacute rejection. This hyperacute reaction, the cause is what? Due to already preformed HLA or ABO antibodies. You didn't perform ABO, proper cross matching, proper procedures, proper HLA matching, and it will cause you what? Hyperacute rejection. Okay. And it is a type of which hypersensitivity reaction? Type 2 hypersensitivity reaction. Okay. And most commonly, it occurs in your renal transplantation. Which transplantation? Renal transplantation. Okay. But please remember, liver is not damaged by your hyperacute rejection, or liver is resistance to hyperacute rejection. The cause is unknown, but in some books it is written like that because liver blood supply is dual blood supply. Liver is given blood supply by your hepatic artery. Liver is mainly 60 to 70% of blood supply of the liver. It is given by the portal vein. It is given by your which vein? Portal vein. Okay. So maybe that is the reason, but exact reason is still unknown. So liver is resistant to hyperacute rejection. But the kidneys or renal transplants are more vulnerable to hyperacute rejection. Okay. It results in what? It results in widespread thrombosis of graft vessels. There will be formation of thrombosis in the graft vessels. And it is which type of hypersensitivity reaction? It is type 2 hypersensitivity reaction. Very good. It is your type 2 hypersensitivity reaction. Okay. So these are the points for hyperacute rejection you must have to remember. Second is your acute rejection. So what is acute rejection now? Acute rejection is when the rejection occurs within 6 months. Okay. Hyperacute is what? Within hours to minute, it is your hyperacute. But if rejection after 1 month, 2 months, 3 months, up to 6 months, then I will call it as acute rejection. Which rejection? Acute rejection. And the cause of acute rejection is your predominantly T lymphocytes. Which lymphocytes? T lymphocytes. Okay. And how you are going to manage this acute rejection? You can reverse it by giving immunosuppressive therapy. Which therapy? Immunosuppressive therapy. Okay. So what immunosuppressive therapy is going? It is now going to act on these T lymphocytes to not proliferate. So when it is not going to be proliferation, there will be no reaction and you can reverse the acute rejection in the patient. Okay. And this is your, please remember, it is your type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction. So what important point which you must have to remember in acute rejection? Number one, it occurs up to 6 months. You perform transplantation and rejection occurs after 4 months, 5 months. It is your which rejection? Acute rejection. Okay. It is which type of hypersensitivity reaction? It is type 4 hypersensitivity reaction. Very good. What is the cause? Due to the proliferation of T lymphocytes. So I can reverse this acute rejection. How I can reverse it? I will give the patient immunosuppressive therapy. When I give the patient immunosuppressive therapy, it will not allow the T lymphocytes to proliferate and there will be no rejection. So I can reverse the acute rejection in the patient. Okay, this is your acute rejection. Third one is your chronic rejection. Occurs after 6 months. First point which you must have to remember, it occurs after 6 months. Number 1 point. Number 2, it is the major cause of allograft failure. So if I ask you second MCQ, what is the major cause of graft failure? And I give you options: acute, hyperacute, and I give you chronic rejection. Your answer will be what? Your answer will be chronic rejection. This is the most common or major cause of allograft failure after 6 months. Okay. And it is your type 4 hypersensitivity reaction also. What happened here in this chronic rejection? In this chronic rejection, the organ transplantation is dominated by vascular changes. And how you are going to know? You are going to know histologically there will be myointimal proliferation in the arteries. So when there is myointimal proliferation in the arteries, what will happen? There will be fibrosis here and it will not give proper blood supply to that organ, resulting in ischemia and fibrosis. Resulting in what? Ischemia and fibrosis. And it is also your which reaction? Type 4 hypersensitivity reaction. Okay. So three rejections you must have to remember: acute, acute rejection, chronic rejection, and hyperacute rejection. Most common cause of graft rejection is your which one? Chronic rejection. Please remember it forever. Now see here, in all these rejections, acute, hyperacute and chronic, in all these three rejections, what is happening? You place the graft in the person and the patient's immune system is attacking the graft. Patient's immune system, this hand is the patient. You place the graft in this patient And now this patient's immune system is attacking this graft, so that's causing your what? Graft rejections, right? But now the fourth complication is your which one? This is your graft versus host disease, GVHD. Very, very important. So what is graft versus host disease? Very simple. Graft versus host disease is what? That graft you have taken from a immunocompetent person, and now you place it in a immunocompromised patient. Now what is going to happen now that this graft is going to attack the immune system of the patient, causing you what? Graft versus host disease. So see here, very simple. I draw the diagram here and then I will explain to all of you. See here, all students. See here. The red one is the graft and this pink one is our person in which you are placing this graft. So what are, we studied it here what? Hyperacute rejection, acute rejection, and chronic rejection. So in all these rejections, this is our patient, this is our graft. In all these rejections, this patient's immune system is attacking the graft. Okay, this patient immune system is attacking the graft. But what is happening in graft versus host disease? That this graft is attacking the patient's immune system and causing here what? Graft versus host disease. And you are going to see in which patients? When you are performing liver transplantation, whenever you are performing small bowel transplantation, or whenever you are performing bone marrow transplantation. So in all these transplantation, there are large number of lymphocytes. And due to this large number of lymphocytes, they are going to attack the immunosuppressed patient, resulting in what? Graft versus host disease. Okay. So this is your what? Graft versus host disease. How you can prevent it? You can give patient irradiated blood so that the lymphocytes will be destroyed. You can give leukodepleted blood to the patient also. Because leukocyte, you will not allow the leukocytes and lymphocytes to pass through it. GVHD is also a main complication of your blood transfusion also. If you understand your blood transfusion lecture complications, one of the complication of blood transfusion is also GVHD. And it is also due to your T lymphocytes. Okay. So whenever you are performing these blood transfusions, how you can prevent GVHD? You will give irradiated blood. You can use leukodepleted blood when you are performing blood transfusion in the patient. Clear to everyone? Clear? Okay. So this is your GVHD now. Now coming into the immunosuppressive agents. So what are the main principles of immunosuppression? So I want to have no immune response from the patient. So there will be no graft rejection. So what is the aim? Aim is to maximize the graft projection from minimum of side effects. Most regimes are your calcineurin blockades. Calcineurin blockades will block interleukin 2. Interleukin 2. And this is your cyclosporine. Cyclosporine drugs. Okay, cyclosporine drugs. Okay. Need for it includes steroids also and antiproliferative agents also. Need for immunosuppression is highest in the first 3 months, but indefinite treatment is needed. It also increases the risk of infection and malignancy in the patient. So whenever you are giving immunosuppressive agents to the patient, the risk of bacterial infection is high in the first month, the risk of cytomegalovirus infection is high after 3 or 6 months. Please remember these two MCQs. Very, very important. So if patient develops infection after 1 month of transplantation, you must have to think of any bacterial infection. If patient develops infection after 3 to 6 months of transplantation, patient is having fever, swinging fever, malaise, other signs and symptoms, you have to think of cytomegalovirus infection. And malignancies, there is a high risk of skin cancers in the patient. Mainly which one? Squamous cell carcinoma, skin cancers in the patient. Okay, it will be increased in these patients. So what are the immunosuppressive agents? See here, a very long list. I'm not going into the details. See here, calcineurin 2 inhibitors blocks interleukin 2 gene transcriptions. Azathioprine prevents lymphocyte proliferation. Corticosteroids, widespread anti-inflammatory effects. Okay. MTOR inhibitors blocks interleukin 2 receptor signal transmissions. But all these agents have their side effects. See here, cyclosporine have nephrotoxicity, hypertension, dyslipidemia, hirsutism, gingival hyperplasia in the patients. Okay. So these have all increased risk of PTLD, post-transfusion related disease, post-transfusion lymphoproliferative disease. And this PTLD is caused by a virus known as Epstein-Barr virus, EBV. It is caused by the virus Epstein-Barr virus. Okay. So these are the side effects of immunosuppressive agents. So see here, side effects of non-specific immunosuppressive infections from opportunistic infections, especially virus, bacterial and fungal virus are common in the first month. Risk of infection is greatest during the first 6 months. Viral infection, see here, cytomegalovirus infection. It is the most common infection seen after transplantation. And how you are going to cover it? You have to give patient intravenously ganciclovir for management and prophylaxis of cytomegalovirus infection after organ transplantation. You have to give what? Intravenous ganciclovir to the patient. Okay. Pre-transplant vaccination must be due to prevent the patient from bacterial and fungal infections. Cancers are more common in transplantations, especially in children. You have to going to see PTLD. What is PTLD? Post-transplant lymphoproliferative disease, and it is mainly caused by a virus known as Epstein-Barr virus, EBV. And there is a high risk of squamous cancer of the skins, and recipients should have a regular skin review. So please remember, patient after organ transplantation, whenever you are giving immunosuppressive agents to the patient, you must have to ask these patients to check their skin, to go to the dermatologist. If there's any skin lesion, you must have to treat it as early as possible. Because of the use of these immunosuppressive agents, patient can have bacterial infections, patient can have viral infections like cytomegalovirus infection, herpes simplex virus infection, Epstein-Barr virus infection, mostly seen in children. And even you are going to ask the patients to not expose your skin to the sun also, because a sun exposure in these patients after transplantation can cause skin cancers in the patient. Okay. So these are the points which you must have to remember. Okay. So these are the side effects of immunosuppressive agents. How you are going to preserve the donated organ. So please remember, donated organ, you are going to take it from the donor and then you are going to flush it with chilled preservation solution in a double or triple sterile bag stored at 0 to 4 degrees Celsius and then immersion in ice while they are transported to the recipient center waiting for the transplantation. Once the donor organ have been excised, samples of donor spleen and mesenteric lymph nodes are obtained for confirmation of tissue typing, cross-matching tests, HLA matching also. Okay. So how you are going to preserve these organs now? So you are going to use these two solutions. This is also your MCQ. The name of the solution is University of Wisconsin solution. So University of Wisconsin solution and Europolin solutions are mainly used for organ preservation. So see here, two things must you have to know. Donor organ, when you take from the patient, you have to remember two times. Warm ischemic time and cold ischemic time. What is warm ischemic time? For example, I take the kidney. And when I take the kidney from the patient's body, now the kidney blood supply is blocked, interrupted. This is known as warm ischemic time. And my aim is to reduce the warm ischemic time as minimum as possible. After taking it, now I have to flush this kidney with our UW solution. Which solution? UW solution, University of Wisconsin solution, or a Eurocolin solution. So when you are going to use this solution, you are going to preserve the kidneys or the organ transplantation organ at a temperature of 0 to 4 degrees Celsius, not more than that. And now you will take this, for example, renal transplantation. Now you take the kidney, place it in a triple sterile bag, and now you will now send it for transplantation. And now when it is going to be transplanted to the other person, it is known as cold ischemic time. So two times you must have to remember, warm ischemic time and cold ischemic time. So what is cold ischemic time? Cold ischemic time is your maximum is seen in the kidneys. So you can transplant the kidney up to 36 hours. Up to 36 hours. Okay. The minimum is with your heart and lungs. Maximum you can transplant the heart within 6 hours. Not more than that. Okay. For example, you take the kidney. If anyone is going to ask you what is the maximum cold ischemic time is seen in which organ, your answer will be kidney. You can transplant this kidney within 18 to 36 hours. This is known as cold ischemic time. Okay. Warm ischemic time is what? You remove the kidney and now you place the kidney, wash the kidney, flush out the kidney with the UW solution and store it at 0 to 4 degrees Celsius. It is your which time? Warm ischemic time. And then you transport it kidney to the other center, to the transplantation center, and you have to transplant this kidney within 18 to 36 hours. Okay, that is, so kidney is having maximum cold ischemic time. Heart is having minimum cold ischemic time. So you take the heart from a patient and now you have to transplant it as early as possible within 3 to 6 hours. Okay, within 3 to 6 hours. So these are your cold and warm ischemic times. Okay, and last one is your outcome for transplantation. So transplantation improves the quality and duration of life. Transplantation outcome has improved over the last 2 decades. Okay. And graft survival after graft survival after kidney, liver, and heart transplantation is more than 90% at 1 year and more than 80% at 5 years. Results of lungs and small bowel transplantation are less good. See here, chronic rejection is the most common cause of graft failure. Okay. So these are the important points relating to the transplantation. If you have any question, you can ask. It's if you have, you can ask. Clear to everyone? I can't hear you. You can write me in the chat. Today's topic is clear. If it is clear, show me the thumbs up. If it is not clear, then also show me the thumbs up. Okay, if it is not clear, show me 2 thumbs up. One thumbs up. Okay. Okay. If it is clear, then I am closing this session. Okay. Thank you very much for listening and thank you very much. Thank you. I really appreciated your response and I will look forward in future also. So if your university will arrange more lectures, then I will give more lectures to you all. Thank you very much. Bye and take care. Bye.